Perioperative care of congenital heart disease patients. This talk really is divided into two main sections. The first part, I'm going to try to focus on some of the basic fundamental physiologic principles that are important in managing children with congenital heart disease, primarily in an ICU setting, either postoperatively or even preoperatively. And then we'll talk a little bit more detail about some of the specific postoperative challenges that we deal with in congenital heart surgical patients. We all want good outcomes, and good outcomes really relies on good planning. While it's important to manage patients well postoperatively, to manage them well preoperatively so they go to the operating room in good shape, the planning of the operation is just as critical. We often do this in a multidisciplinary format where many of the people on the team put their heads together to reach a consensus about the plan. But there's some important key features or components of good planning, particularly related to planning for management of children with congenital heart defects. First, you have to know the anatomy, and the anatomy is often described by echocardiography and other diagnostic tests. You have to understand the physiology. What are the impacts of the anatomic problems, and how are they affecting the child? How it's affecting the heart function, the lung function, other organ functions. We have to have an understanding of the options. What are the different choices to deal with the problem? And in some cases, there may be many, with pros and cons that are different among the different options. And it's also important to understand the timing. You want to take advantage of an optimal window of opportunity in some situations, or avoid moving too quickly when risk factors may be able to be mitigated by further delay or management of those specific issues. Well, what I want to focus on first for a little while is some fundamentals about oxygen, and specifically oxygen delivery. And whether it's preoperative or postoperative care, the primary function of the cardiovascular system is oxygen delivery to the tissues. And so having a good understanding of oxygen delivery physiology, what goes into it, how do we assess it, how do we monitor it, is sort of a key center point of crafting plans to managing children with complex heart problems. So I like this analogy a lot for understanding the principles of oxygen supply or oxygen delivery. Oxygen is brought into the body via the lungs, so we can look at the lungs as the gas tank, the supply area. Oxygen's consumed in the body by the tissues, and we have a delivery system. And the train analogy is a great way to help remember the key components that determine oxygen delivery. And oxygen delivery is really dependent on just three things: hemoglobin concentration, oxygen saturation, and cardiac output. And the reason the train analogy works so well, at least for me, to remember these components, is that the hemoglobin concentration, or what's the carrying capacity of blood, because most of the oxygen is carried on the hemoglobin molecule. The hemoglobin concentration is like the boxcars of the train. How many boxcars do we have? How much product, oxygen in this case, can the train carry at a time? Oxygen saturation is how full are those boxcars? How highly saturated is the hemoglobin with oxygen? And then cardiac output is how fast is the train running. So those three features, how many boxcars do you have, how full they are, and how fast is the train moving, all are what determine the oxygen delivery on a minute-by-minute basis. And understanding that, it's helpful to then talk a little bit about how do we typically assess oxygen delivery or the adequacy of oxygen delivery. And what I want to point out in the next couple slides is how mixed venous oxygen saturation turns out to be a very valuable tool to be able to make that assessment. So here's an example of a 10-kilogram child with normal cardiopulmonary physiology. We have a oxygen saturation that's 95%, a normal hemoglobin level of 13 grams per deciliter, and a normal cardiac index of 3 liters per minute per meter squared. If we do the math, we can calculate what the oxygen delivery is in mils of oxygen per minute. And we know generally the oxygen consumption is about 150 mils per minute per meter squared. That can be measured in certain circumstances, but what it means is that as the blood goes through the tissue, some of that oxygen is consumed, so that when the blood gets back to the filling station, back to the lungs, if you will, the oxygen saturation is less than it was in the arterial blood. So mixed venous oxygen saturation is the oxygen saturation of all of the systemic blood as it's returning to the heart. Usually in a normal heart measured at the pulmonary artery level before it gets into the lungs. In patients with congenital heart disease, usually we use measurements in the vena cava before potential contamination due to left to right shunts. But the bottom line is, in a normal situation, mixed venous saturation is usually around 70%, which means that the body utilizes about 30% of the oxygen that's delivered to it at any given time. Now, what if the cardiac output's low? Same child, we're just going to change one of those determinants of oxygen delivery. So we still have fully oxygenated blood, 95% saturated. We still have a normal hemoglobin level, but if we knock the cardiac index down by half to a low cardiac output state of 1.5 liters per minute per meter squared, oxygen consumption hasn't changed. We've still got the same number of boxcars. They're all full, but the train is moving more slowly. And as it moves through the tissues more slowly, it's obviously delivering oxygen at a slower rate, and more of it will be consumed in the tissues as that blood goes through the tissues. So the blood returning to the right side of the heart, the mixed venous saturation will be lower. And so that lower mixed venous saturation is a reflection of the fact that oxygen delivery was lower because more was removed. Another example is anemia. Again, same patient with fully saturated blood, 95%. Now we change the hemoglobin down to 8 rather than 13 with a normal cardiac index. So we have fewer boxcars. They're all full. The train's moving pretty quickly, but those boxcars will be more depleted coming through the tissues, and again we'll see that the mixed venous saturation will be lower. So mixed venous saturation can be an indicator of poor oxygen delivery, particularly when we use it in comparison to the arterial saturation, and we can assume in many patients that that's normal, but again in congenital heart patients that may not be 100%, 95%. So the real difference is what's the difference between, or the real important issue is the difference between arterial and mixed venous oxygen saturation. And if that difference widens, the mixed venous saturation being lower, that's telling us that oxygen delivery may be inadequate. And it's due to one of those three components or a combination of them. And in most situations, we know what the arterial oxygen saturation is, and we know from continuous monitoring that it usually is staying relatively stable. And we know over the short term that hemoglobin levels usually are pretty stable, so that in the end, fluctuations on a minute-to-minute, hour-to-hour basis in patients, fluctuations in the mixed venous saturation on a minute-to-minute or hour-to-hour basis, are largely reflecting changes in cardiac index or cardiac output. And so that's why mixed venous saturation monitoring can be a really valuable tool in cardiac patients as a way to assess cardiac index as one of the key components of oxygen delivery. And while mixed venous saturation can be measured by sampling mixed venous blood, that can become cumbersome, particularly in smaller children, and it can't be done continuously. And that's where NIRS monitoring comes in as a great adjunct in our population for monitoring mixed venous saturation. So NIRS, near-infrared spectroscopy, cerebral or somatic tissue oxygen content monitoring, it gives us a venous-weighted estimate of tissue oxygen concentration. And it's been shown that it tracks pretty well with measured mixed venous saturation. And that's what's shown in this diagram with a measured mixed venous saturation on the y-axis and the RSO2, the regional cerebral or the regional oxygen saturation, tissue oxygen saturation measured by a NIRS probe on the x-axis. And these are the monitors we're familiar with using in the pediatric cardiac OR and pediatric cardiac ICU. We usually use multi-site monitoring. And the way this works is that it gives us a oxygen saturation of tissue. And we're interested usually in the brain tissue or the solid organs, kidney or liver, because the tissue oxygen saturation is largely a venous saturation, because the largest component of blood in the tissues is venous, followed by capillary and least of all arterial. So if we could measure the saturation in the cerebral cortex, that would be a venous weighted specimen, and as I said, that correlates pretty well with mixed venous saturation. And the way these probes work to get an estimate of the actual tissue that's obviously deep under the skin is using a probe with a light source and two sensors. And the sensors are 3 and 4 centimeters from the light source. And when we apply this to the patient, in this diagram it's on the head, the light goes into the tissue, some of it's reflected back and picked up at the sensors. And the light that is picked up by the near sensor hasn't traveled as deep into the tissue compared to the light that is picked up by the far sensor. And since we're really interested in the oxygen saturation of the tissue deep in the middle of the area under the probe, and not so much interested in the oxygen saturation of the skin or the skull or the dura, the device subtracts the superficial sensors reading from the deep sensors reading, and so that leaves us with an estimate of tissue oxygen saturation at a point about 1 centimeter or 2 deep from the skin under that center part of the probe. And so that's how the system works to give us that tissue oxygen saturation. And again, it's a reflection of mixed venous saturation, which we can use as a continuous and non-invasive trend monitor for cardiac output, or at least oxygen delivery. So that's the first important point I want to make, and we'll come back to some use of that later. Second point I want to make about children with congenital heart disease is that we see patients in our units that at baseline have a fairly wide range of oxygen saturations depending on what stage in their management they are. And when we do just arterial oxygen saturation monitoring on these kids, we can see a lot of fluctuations, particularly in the cyanotic kids. And there's some basic physiologic reasons behind that. So kids with normal oxygen saturations, their oxygen saturation doesn't fluctuate all that much with doing daily activities, whereas we may see much greater fluctuations in a child with tetralogy of Fallot or a shunted single ventricle child whose baseline saturations may live in the 70s or 80s. The reason behind that fluctuation is the oxyhemoglobin dissociation curve and its sigmoid shape. So again, this is a curve that graphs oxygen saturation on the y-axis and PO2 on the x-axis. And for most people with a normal heart, you may be able to fluctuate your PO2 by 20 millimeters mercury by holding your breath for a second or something like that. And because you're up on the flat part of the oxyhemoglobin dissociation curve, it really doesn't impact oxygen saturation very much. On the other hand, if you're a patient whose baseline oxygen saturation is 80, that correlates with a PO2 of about 50. And the same 20 millimeter mercury drop in PO2 in this patient is going to result in a lot greater change in their oxygen saturation because they're living on the steeper part of the oxyhemoglobin dissociation curve. So just an important thing to keep in mind, because sometimes it's tempting to overreact to fluctuations in oxygen saturations when there's a fundamental physiologic reason why we would expect to see a little more fluctuation in a child who's living at a little bit lower part on the curve anyway. The next concept I want to talk about is QPQS, or the ratio of pulmonary to systemic blood flow. It's a number that we calculate often in the cath lab when we're evaluating patients' cardiopulmonary physiology. It's a calculation we can sometimes do an estimate of at the bedside in some of the complex patients that we manage. And it's important to understand the value of this and how we generate this information. So again, QPQS is the ratio of pulmonary blood flow to systemic blood flow. And Q is flow, and flow by Fick's equation is calculated by the oxygen consumption divided by the oxygen content difference between arterial blood and venous blood. Whatever blood's going into the tissues versus whatever's coming out will give us a calculation of flow. Now, if we want to express things as a ratio of pulmonary and systemic blood flow, the amount of oxygen consumed is equal to the amount of oxygen that's packed onto the blood in the lungs. So those two values cancel each other out, and the ratio then reduces to a formula of the systemic AVO2 difference divided by the pulmonary VaO2 difference. And so to calculate QPQS, you need 4 saturations: arterial oxygen saturation minus mixed venous oxygen saturation, so the difference between aortic and vena caval oxygen saturation, and then on the pulmonary side, pulmonary venous oxygen saturation and pulmonary arterial oxygen saturation. And what's really handy for bedside calculations in some of our complex patients, such as a shunted single ventricle patient, is that many of our complex single ventricle patients, we know that their pulmonary blood flow is fully dependent on either a shunt or it's coming off the same single ventricle that's supplying blood to the aorta. So aortic and pulmonary artery saturation in many single ventricle patients is known to be the same. And so that simplifies things. We're monitoring arterial saturation with a pulse ox. We can then assume that the pulmonary artery saturation is the same in many of these patients. Mixed venous saturation can be estimated using the NIRS monitoring that we talked about a few minutes ago. And then pulmonary venous saturation, as long as the lungs are working pretty normally, we can assume that most of the blood passing into the lungs is getting fully oxygenated. So pulmonary venous saturation in the face of healthy lungs can usually safely be assumed to be about 95%. And so at the bedside, you can often do a calculation of the pulmonary and systemic blood flow ratio. And how is that useful? Well, for most of us and most people with a normal heart, the QPQS ratio is 1:1. The pulmonary blood flow equals the systemic blood flow. We have 2 ventricles, and each one's doing a single, if you will, cardiac output unit of work. And that usually results in good cardiopulmonary efficiency, and the heart's healthy and happy doing that amount of work. By comparison, for patients with single ventricles, QP-QS ratio can vary widely depending on a number of factors. How easy is it to get blood out to the lungs? Is there physical obstruction? Are there issues with resistance? And in many cases, the QP-QS ratio is greater than 1, particularly in the preoperative period, but sometimes even early postoperatively. And it's important to remember that that single ventricle has to do all of that work. It has to do QP and QS. You've only got one ventricle. It's supplying the energy often for both the pulmonary and the systemic blood flow. So we have a single ventricle that essentially is doing 2, 3, 4 times the normal amount of work that a normal ventricle would be doing. So at least 2 to 3 times the normal number of cardiac output units, if you will. So it's not surprising that in some of our patient populations, we're severely stressing the work that that single ventricle needs to do. And that's why it's important to sometimes have a handle on how much extra work are you asking it to do. What is the QP-QS? You want to get that as close to 1-to-1 as possible, which usually means it's not going to have to work too terribly hard, but still optimizes oxygen delivery to the tissues. And in some of our management, we're focusing on balancing QP-QS. So can we manipulate things to get the QP-QS balance a little closer to normal so that we're getting enough oxygen into the blood, enough pulmonary blood flow to get oxygen into the blood, but not too much so that we're not overworking that ventricle. Most of the time, we're focusing on manipulating the pulmonary blood flow and not so much decreasing pulmonary blood flow, because a lot of the manipulations that we can do at the bedside don't necessarily decrease pulmonary blood flow, but some of them can increase pulmonary blood flow, which is often something that we'd want to avoid. So focusing on the impact of FiO2 on pulmonary blood flow. With patients with unrestricted pulmonary blood flow in a single ventricle circulation, we want to avoid excess oxygen exposure that'll be a pulmonary vasodilator and increase pulmonary blood flow at potentially the expense of systemic blood flow. We want to pay attention to carbon dioxide. Some children will hyperventilate. A child on a ventilator, sometimes inadvertently, we hyperventilate them, and dropping the PCO2 causes pulmonary vasodilation, and again, it causes an unfavorable balance of QP-QS. So paying attention to the PCO2, keeping it in a normal range, even artificially elevating it as possible by mixing in carbon dioxide into the inflow gas mixture to act as a vasoconstrictor has been used. Judicious use of vasodilators, or paying attention to what vasodilators a patient's on, is important. In many newborns with complex congenital heart disease, they have ductal-dependent blood flow, either systemic or pulmonary. And we use prostaglandins to maintain ductal patency to preserve pulmonary or systemic blood flow. It's important to recognize that prostaglandins are a potent vasodilator. And while the effect of prostaglandins to maintain ductal patency isn't usually dose dependent, it usually works just fine at a relatively low dose of prostaglandins, the vasodilatory effects of prostaglandins are dose dependent. So we want to make sure we're not turning up the prostaglandins when we have adequately patent ductus and inadvertently causing pulmonary vascular vasodilation with increased pulmonary blood flow. And then in some patients who are on a ventilator already, we can actually increase the vent pressures, increasing the PEEP levels as a way to limit pulmonary blood flow and increase the pulmonary resistance slightly to try to balance QP and QS. Manipulating systemic blood flow is a little more difficult. A patient that has ductal-dependent systemic blood flow, obviously we want to make sure that ductus is widely patent, but maneuvers to really modify systemic blood flow to improve it using vasodilators usually aren't very effective, and they unfortunately aren't very specific to the systemic circuit and work equally on the pulmonary circuit. In addition to manipulating one resistance or the other to manipulate the QP to QS ratio, manipulating total blood flow, or QPQS, or augmenting cardiac output can be an important tool in maintaining adequate oxygen delivery. It doesn't necessarily balance QPQS ratio. It may elevate both, which can improve overall oxygen delivery. And then in some cases, we may need to actually try to decrease oxygen utilization if we are limited in our ability to improve oxygen delivery to the tissues. So this is a helpful diagram that I like to use to explain how QPQS ratio and total cardiac output, or QP plus QS, relate to one another. So this is a diagram that was generated from a mathematical model of a single ventricle circulation. On the y-axis, we have systemic oxygen availability, which is oxygen delivery. On the x-axis, we have QPQS ratio, and this is not a linear axis, you'll notice. There's a shaded area down at the bottom. So below this line in the shaded area is the area where oxygen delivery is inadequate, and we start to see acidosis. And so obviously we want to keep the patient up in the adequate oxygen delivery range in the white part of the graph. And each of these curves represent a different cardiac output as they go higher and higher, higher cardiac output, and shows us what the relationship is between QPQS and oxygen delivery. So there's going to be a peak somewhere in the middle of this curve, and it's close to 1-to-1, where oxygen delivery will be optimized for a given cardiac output. If we go in either direction from a balanced QPQS, either excess pulmonary blood flow at the expense of systemic blood flow, or excess systemic blood flow with limited pulmonary blood flow, will start to decrease oxygen delivery. And what's important in this diagram to recognize is that at a lower cardiac output, the intersection of the curve with the danger zone line is going to be relatively narrow. So it may be important to maintain that QPQS at a very narrow window here to keep adequate oxygen delivery. Whereas at a higher cardiac output, the intersect becomes a lot wider, and then QPQS ratio almost becomes irrelevant because oxygen delivery will be adequate at a very wide range of QPQS values. So I think what's helpful is if you've got a patient that has adequate oxygen delivery, great. It's helpful to calculate the QPQS if you're worried that the oxygen delivery isn't adequate and you're trying to figure out which direction you want to try to push things up the curve to balance QPQS. And it also gives you a sense for, even if you're adequate, where on these curves do you think you're living? Many times, if we're in a situation where we're not satisfactory in our oxygen delivery, it's going to be a combination of both trying to balance QPQS, move things back toward a 1-to-1 balance from wherever we are, often pulmonary overcirculation, but also to try to move things up to a higher curve, increase overall cardiac output, because both of those may be effective in moving the patient from an oxygen deficit situation to an oxygen surplus situation. So again, back to the slide I had up there before, it's all about oxygen delivery. It's really important, both preoperatively and postoperatively, to keep that really as a central focus for managing patients with cardiac problems, is that the whole reason the heart and lungs are there is for oxygen delivery to the tissue. We need to be paying attention to its adequacy. And there's a number of ways we evaluate it. I've mentioned in some of the previous slides some of the ways we evaluate it, but don't forget about some of the most basic ways that we assess adequacy of oxygen delivery, such as physical examination, capillary refill, the quality of pulses, comparing central pulses to peripheral pulses, and skin temperature are simple measures that can often give us a lot of information about the adequacy of cardiac output and oxygen delivery. Other clinical monitoring is important, such as hemodynamics, blood pressure, heart rate, looking at the effects of cardiac output on the end organs. We frequently follow urine output as a fairly sensitive indicator of the adequacy of oxygen delivery or cardiac output. We have non-invasive monitoring, which is particularly helpful in children because we don't often have the luxury of being able to easily place central access lines. So pulse oximetry for arterial oxygen saturation, multi-site NIRS for estimations of mixed venous saturation have become fairly standard adjuncts in the pediatric cardiac ICU. And then we do have invasive monitoring. We can measure filling pressures, central venous pressures, left atrial, right atrial pressures. And in bigger children, cardiac output monitors, either with Swan-Ganz catheters or Pico catheters. And then in addition to specific things we monitor on the patient that I've mentioned, we follow lab values, which are a reflection of adequacy of oxygen delivery, acid-base balance on blood gases, lactate levels, or periodically measuring mixed venous oxygen saturations. So now let's turn to some of the things that keep us up at night. So what are the postoperative problems that we frequently see in patients undergoing cardiac surgery? First of all, as I alluded to in some of the previous slides, we have a lot of data upon which to rely in a postoperative patient. And there's lots of postoperative lines or intraoperative monitors that we use that sometimes bombard us with a lot of information. And some of the challenge in managing critically ill patients is to integrate all the data that we get, because not always does the data agree with other components of the data. So we have to identify what we trust most, identify why some of the data may not be trustworthy, to get an overall sense for the adequacy of cardiac output, the stability of the child. And so on this slide, we list many of the monitors and lines that we use, and some of them are things that pretty obvious how we use them: pulse oximetry, arterial catheters for monitoring continuous blood pressure, sampling labs, central venous catheters, pulmonary artery catheters. Chest tubes I put on this list. The chest tube is an important monitor as well, and particularly in an early postoperative patient. What's the chest tube drainage? The concern, if there's a lot of drainage that suddenly stops, is a problem with hemodynamics due to pericardial tamponade. So it's important to get information from all of your resources in the postoperative patient. Most important is don't forget your ABCs. Even though we're dealing with kids with complex cardiac problems, even though we're in the cardiac ICU, I've seen more patients undergo serious instability or cardiac arrest because of airway and breathing problems, particularly in younger children, than from cardiac-related problems. So don't forget, if a patient's severely unstable, to work through things in a systematic way. And airway and breathing should at least be considered first before we start focusing on circulation. We have to make sure all are acceptable. We know that patients undergo what's characteristically referred to as a postoperative slump in cardiac output. I think people clinically had recognized this for a long time. Sometimes it was clinically obvious, sometimes it wasn't. These are some data from a study that was done a number of years ago in patients with transposition of the great arteries. It was actually a study designed to compare deep hypothermic circulatory arrest with hypothermic low flow. But one of the things that was interesting about this study was that all of the patients had the ability to measure cardiac output postoperatively. They all had right atrial and pulmonary artery catheters placed, and thermodilution cardiac outputs were able to be obtained on these kids postoperatively. And so What they found was, and so this is newborns, arterial switches, two ventricle circulations, and many of these kids clinically were stable. The bottom chart shows the levels of inotropic support, and it was pretty much static. There wasn't a lot of manipulation in this first 24 hours post-op of their inotropes, so clinically these kids appeared to be stable. But in the top graph, it shows what the actual measured cardiac index was, and it shows that very reproducibly, at about 8 to 12 hours post-operatively, there would be a nadir in cardiac output, even if it wasn't clinically evident, as reflected in the lack of response by caregivers to turn up inotropes. And that's something that we characteristically expect. And there's a number of reasons for that. Low cardiac output is clearly one of the main things that concern us in the perioperative management of children who undergo heart surgery. And cardiac output, as we know, is determined by heart rate and stroke volume. And stroke volume can depend on preload, how much you've got the ventricle filled, on contractility of the ventricle, and on afterload, how much resistance it has to pump out against. So when we're dealing with cardiac output, we have to sort of tease things apart and identify what of the components or contributors to cardiac output are problematic. There are a number of reasons why we may see low cardiac output in postoperative patients. They may be preload issues, we may see contractility issues, we may see afterload issues, we may have residual cardiac lesions, and we may have rhythm issues. And so let's talk about each of those in sequence. Some of the preload issues may be simple hypovolemia. Is the tank not full? Postoperative patients may be bleeding. If chest tube output is excessive, intravascular volume may be compromised. Or sometimes a little bit later into the patient's postoperative course, we often get pretty aggressive with our diuretics, and sometimes at the expense of driving the preload down to unacceptable ranges to support an adequate cardiac output. As I mentioned a little bit ago, tamponade is something that is important to consider in a patient that may have early postoperative low cardiac output, particularly if there's been a lot of chest tube drainage, particularly if it's sort of stops over a relatively short period of time, may indicate that the bleeding hasn't stopped, it's just not coming out of the chest tubes, and that may be building up pressure around the heart, which impedes filling of the heart, becoming a preload issue. We may have contractility issues, and these are common after cardiac surgery. There may be myocardial dysfunction due to hypoxia or ischemia. We know to do cardiac repairs, we stop the heart. We have a planned period of ischemia of the myocardium. We usually plan for it by giving cardioplegic solutions to protect the myocardium, but it still has a period of ischemia that may lead to postoperative dysfunction. We may injure the myocardium as a component of doing the operation. We may have to perform a ventriculotomy to do a repair of tetralogy of Fallot, and that cut and sewing on the ventricle may impact ventricular function. And we may have inadequate intraoperative protection. While we may deliver cardioplegia to the heart, our delivery may not be ideal, or their cross-clamp time may be longer than expected. So our planned intraoperative protection of the myocardium may not be all that we hoped, and that may lead to myocardial dysfunction postoperatively. There can be acidosis, electrolyte imbalances that are common after cardiac surgery, and that may impact myocardial function, particularly some imbalances in things like calcium and magnesium. And then we may see ventricular interactions as a reason for contractile issues. The right ventricle may be very unhappy and stiff because it came into an operation hypertrophic, it was cut on, and its volume loading changed. And a right ventricle may be very dysfunctional after an operation, and because it shares a common wall with the left ventricle, that unhappiness of the right ventricle may translate into unhappiness of the left ventricle as well, compromising overall cardiac output. And then afterload issues. We don't often see problems with systemic vasoconstriction as a primary problem, but pulmonary hypertension can be seen very often in postoperative patients, particularly newborns, where acute increases in pulmonary resistance, pulmonary vasospastic crisis, can lead to pulmonary hypertension that can cause acute right ventricular dysfunction. And if the right ventricle doesn't work well, the left ventricle doesn't work well. So leading to overall decreases in cardiac output that sometimes can be quite sudden and dramatic, and sometimes be more indolent and chronic. We may have residual lesions. Anytime a patient goes to the operating room, you have to think about what was done and what wasn't done. Sometimes these residual lesions are known. We expect them. We know we went to the operating room to fix a problem, but we know that there are certain aspects of a patient's anatomy that we haven't addressed with the repair, and that may be residual impediments to optimal cardiac function. Or we may not have been able to do the optimal repair that we had planned. And sometimes we know that. That's why where the value in postoperative transesophageal echocardiograms and other investigations we do coming off bypass can help inform the postoperative caregivers to understand what liabilities or handicaps do we still possibly have to normal cardiac function. And then some residual lesions are unknown or unexpected. They weren't picked up by the postoperative transesophageal echo, or they developed afterwards. If the take-home message is, if things don't make sense, if a patient's in low cardiac output, if it doesn't make sense based on what we expected to have done in the operating room, we need to get more information. You always have to continually ask yourself why, if things aren't going the way you planned, and if you can't answer it with the available data, you need to investigate further and get more data. So next, arrhythmias. So arrhythmias certainly are a reason for problems with cardiac output, and arrhythmias are not uncommon in postoperative patients for a number of reasons. Many operations involve surgical manipulation of or near the conduction system, and that can affect the rhythm. We will see elevated catecholamine levels postoperatively, and elevated catecholamine levels can cause irritability of the heart, which can be predisposed to arrhythmias. And the elevated catecholamine levels may be endogenous or exogenous. It may be the patient's in pain and they're releasing their own adrenaline from the adrenal glands, or they may be on IV inotropes that we are exogenously giving them to improve cardiac output, but that may increase arrhythmogenicity. We know there are fluid and electrolyte shifts that occur in the early hours and days after operations, and that may lead to a increased risk of irritability and arrhythmias. And then hemodynamic and cardiodynamic changes are just the wall tension of the heart, the perfusion of the myocardium. That can affect the vulnerability of the myocardium to arrhythmias. And why do arrhythmias cause problems? Well, as we said on a prior slide, cardiac output is the product of stroke volume and heart rate. And so heart rate's obviously a key contributor to cardiac output. Slow rhythms, the heart rate's too slow, unless there's a limit to how much the stroke volume can increase to maintain adequate cardiac output in some situations. Fast rhythms cause problems because diastole is too short. If the heart's going so fast, the relaxation phase is so short that the ventricle doesn't fill adequately, and that compromises stroke volume. And then also, rhythms can cause problems in the loss of AV dissociation, the loss of synchrony. While the atrium doesn't exclusively fill the ventricle, that atrial contraction fills the ventricle at the end of diastole a little bit more, which can be an important contributor to 10 to 20% of cardiac output by priming that ventricle to eject more efficiently. So this schematic represents the conduction system and points out a couple of key components of the conduction system that are worth keeping in mind when a postoperative patient's being evaluated for a possible arrhythmia. The reason the anatomy is important to keep in mind is because if you understand the operation that was done, you will sometimes be clued into the fact that certain parts of the anatomy may have been at risk for damage. So the sinoatrial node, where the rhythm typically starts, the fastest pacemaker of the heart, is at the junction of the superior vena cava and the right atrium. So an operation such as a bidirectional Glenn, where superior vena cava is transected and anastomosed to the right pulmonary artery, may put the sinus node at risk for damage. The impulses then travel through the atrial myocardium, but the zone between the atria and the ventricle is electrically insulated, so messages can't get across except for one area, so that the impulse of contractility, of depolarization from the atrium, is congregated at the AV node, which sits at the base of the right atrium, and then at one spot that works as a relay station, and the message goes across the His bundle as the one place that can bridge across from the atrium to the ventricle, and then rapidly spreads around the myocardium via the His-Purkinje fibers. So that AV node and His bundle at the base of the right atrium and the upper portion of the ventricular septum is an area that's particularly vulnerable in closure of ventricular septal defects or other operations that are near the inlet valves of the AV junction of the heart. Irregular rhythms are characterized in a number of different ways. Fast or slow is one way, and in postoperative patients we can see slow rhythms, the most common being heart block, usually from injury to the AV node or His bundle. Heart block comes in a few different flavors. First-degree heart block is where the PR interval is prolonged, but there is a QRS complex, ventricular contraction, after each P wave. On the other end of the spectrum, third-degree heart block or complete heart block is where none of the impulses are getting through. None of the P waves are followed by a QRS. And second degree, as you'd expect, is somewhere in between. Some of the messages are getting through and some of them aren't, and may follow different patterns, may not follow a pattern, giving different types of second degree heart block. And then sinus node dysfunction. If the sinus node's been damaged, then the next faster area of automaticity further down in the heart will usually take over, but will be slower. So when the sinus node doesn't work, usually it's the AV node that's the next fastest area that will take over conduction, resulting in a junctional bradycardia, a junction referring to the AV node. Fast rhythms, PSVTs, atrial fibrillation or flutter, or junctional ectopic tachycardia are some of the more common fast rhythms we see in postoperative patients. One thing that's helpful in looking at fast rhythms is understanding the mechanisms of tachycardia. And this slide tries to demonstrate two general categories of tachyarrhythmia mechanisms. One's reentry and one's automaticity. And it's helpful to understand these because it can help in both diagnosing and guiding management of the arrhythmia. So a reentrant rhythm, if an impulse has to go from point A to point B, from the high circle to the low circle, whether that's the sinus node to the AV node or the AV node down to the ventricle, there's often a couple of different pathways that impulse can travel, and usually it travels by the different pathways and gets from point A to point B at roughly the same time via various different pathways. And after a tissue's been depolarized, it has a period of refractoriness where it won't listen to any messages. But sometimes there can be a slow pathway. So one of the pathways is a bit slower, and when the signal goes down the faster pathway and gets to its destination, the impulse may head back in the other direction along the slow pathway because that area is not yet refractory, and that can set up a cycle that can result in a tachycardia. And the characteristics of that is that it's usually sort of a sudden on, sudden off. It's a sudden jump in rate, and it's a fixed cycle length because that reentrant circuit is going to have the same cycle length of the time it takes to go around that cycle, and the rate that is a result of it in terms of tachycardia is going to be relatively fixed. And when they stop suddenly. If you can interrupt that cycle, it stops, and suddenly they're down to a normal heart rate. Examples are paroxysmal supraventricular tachycardia, Wolff-Parkinson-White, a flutter. These are rhythms that can, again, be recognized by the fact that they are sudden in onset, sudden in offset, and these are the ones that can be terminated by introducing an extra beat, somehow breaking the cycle, whether it's synchronized cardioversion, whether it's overdrive pacing, whether it's breaking the cycle with adenosine. On the other hand, automatic rhythms are kind of like a seizure, where there's an irritable focus that just decides to go haywire. And it can decide to go really fast, it can decide to go a little bit fast, it can fluctuate all around. And it doesn't necessarily stop and start on a dime. There may not be a sudden jump or a sudden drop in the heart rate. It may be more gradual, which means they can sometimes be a little bit more difficult to appreciate. And they can have fluctuation. And these don't typically respond to maneuvers that break the cycle. They don't respond to cardioversion, they don't respond to adenosine, they don't respond to pacing. They are exacerbated by things that make the myocardium or that area more irritable, catecholamines and the like. What I want to take a couple moments on is to focus on junctional ectopic tachycardia, which is one of the rhythms we see in postoperative patients that can be particularly challenging to deal with. When we look at a rhythm strip, in this case, we see a relatively rapid rate, but it's narrow complex. So it's using the normal His-Purkinje system, but we don't see P waves. At least they're not immediately evident. Sometimes with junctional ectopic tachycardia, we may see P waves, but they're coming at a slower rate than the QRSs, or sometimes we'll even see inverted P waves right up against the front end or buried in the QRS complex. This is a picture of the bedside monitor in a patient with junctional ectopic tachycardia. Their heart rate's a bit fast, their blood pressure is maybe a little bit soft. What I want to draw attention to is the lower tracings, the central venous pressure tracings. With a normal central venous pressure tracing, you will see in normal sinus rhythm a biphasic waveform. For every ventricular systole, for every cardiac cycle, the central venous pressure usually has two humps. There's one for atrial contraction, and then when the ventricles contract, the AV valves close suddenly and then push back into the atrium, resulting in a double humped contour. With junctional tachycardia, often the atria and ventricles are contracting simultaneously, so we get a single hump, and that's what we see particularly in that lowest tracing of a single canon A wave of the atrial tracing. Looking at these atrial tracings can be a really useful tool in identifying this as arrhythmia, because if the patient came back from the operating room with a normal central venous tracing, a biphasic waveform, and they've sped up a little bit, and we're not sure if they're just in pain or is this junctional tachycardia, if we notice that the central venous pressure tracing has changed, that gives us an idea that, hey, wait a second, maybe we're dealing with a tachyarrhythmia. And this is the same patient after initiation of pacing, after slowing them down with amiodarone. We're now running at a heart rate of 145. The blood pressure is better, and now on that lowest part of the tracing, we see what I was referring to as a normal biphasic atrial waveform. And so a lot of times we use central lines to look at filling pressures, and yes, that's useful, but we don't often pay attention to the waveform, and it can be extremely useful, particularly in analyzing patient for some dysrhythmias. Junctional ectopic tachycardia can be really difficult because it's an automatic rhythm that's very hard to slow down. Years ago when I was training, we didn't have any good drugs to slow things down. We would rely on cooling the patient to very low temperatures to try to get some control. The treatment of junctional ectopic tachycardia relies on first focusing on rate control and then reestablishing AV synchrony, because it's the loss of both of those things that can result in low cardiac output. We accomplish rate control not so much by actively cooling a patient, but certainly avoiding hyperthermia. And sometimes patients in low cardiac output clamp down and they elevate their temperature, and that can exacerbate the tachycardia. We want to limit the catecholamine barrage, both intrinsic, if we can turn down the inotropes infusions without compromising cardiac output, that's ideal. Or that's for the extrinsic. For the intrinsic catecholamines, we want to sedate the patients heavily so they're not in pain, so they're not barraging their AV node with a lot of catecholamine output from their adrenals. And then finally, and now most importantly, pharmacological. Now, since the advent of amiodarone, we have a good drug that can very effectively, if you give enough, slow down the junctional tachycardia so that you can get things in a more reasonable rate for adequate cardiac output. Then we can establish AV synchrony by initiating pacing, either atrial pacing, if the AV conduction's intact, or AV pacing. Which leads us to a quick discussion of pacemakers. So pacemakers have been around a long time, and they have been extremely helpful in mitigating the morbidity of some of the dysrhythmias I've been talking about, particularly heart block, which often are temporary but could be fatal if we didn't have a way to pace the heart while we're waiting for the heart block to resolve. When we talk about pacemakers, we're usually talking in code. There's a typical 3-letter code that we use to talk about pacemaker programming. It's important to have at least a general understanding of what those letters refer to. It's part of this generic code that's been adopted by national rhythm societies. It's actually a 5-position code. The 4th and 5th position usually we don't use commonly. Those are predominantly in permanent pacemaker systems, but it's important to understand what the first 3 letters of the code that we most commonly use refer to. So, for example, we may say the pacemaker is programmed AAI or VOO or DDD. Those letters refer first to the first letter tells you which chamber is being paced. Is it the atria, is it the ventricle, or can both chambers be hooked up to pace? Second letter refers to which chamber is sensed, because contemporary pacemakers have the ability to both pace the heart but also listen to the activity along the pacemaker leads and interpret whether the heart, the atria, the ventricle are beating. And so which chamber is sensed is what's referred to in the second. And if it may just listen to the atrium, may listen to only the ventricle, or it may be able to listen to both chambers. And then the third position is what does it do in response to sensing? So if it senses a normal P wave, is stimulation of the atrium inhibited? So I is the most common letter used in the third position if we're talking single chamber pacing. So AAI would be single atrial pacing with atrial sensing, and pacemaker is going to be inhibited from firing if it senses a normal P wave. D refers to the fact that that's in effect for both chambers. The main parameters that we set on temporary pacemakers are the rate or the output. While there's the ability to customize a lot of the other settings, it's really the rate and the energy output that are the things that we most commonly set, and usually that's what we write in our orders. So now let's move away from some of the cardiac problems. Real briefly, we'll run through some of the other systems that are commonly our focus in postoperative cardiac patients. Renal insufficiency is something we focus on. Not only are the kidneys a good reflection of adequacy of cardiac output, when we have inadequate cardiac output, or sometimes just placing a patient on cardiopulmonary bypass for a while, can impact renal function. And when renal function is down, we have edema. Edema makes all the organs of the body work less well, and that can be a problem. There are rifle criteria that have been modified for pediatric patients that kind of define the degree of renal insufficiency. Commonly we see mild degrees of renal insufficiency in many complex patients after cardiac surgery. There have been some studies that have looked at the use of renal replacement therapy early after operations. So even if there isn't significant renal injury, that early dysfunction of the kidneys that results in edema, which may affect the ability for the lungs to exchange oxygen, may affect efficiency of the myocardium to contract, may have an impact on survival or complications. And some studies have looked at the institution of early peritoneal dialysis versus waiting for classic indications of renal insufficiency and seeing if that has an impact on outcomes. And some studies have shown, in fact, that if you do use renal replacement therapy, knowing that the kidneys are going to have a period of poor function in some of these complex patients, but just go ahead and take over that function and empirically initiate dialysis, it can be associated with improved survival. And so at our institution a number of years ago, we set up a protocol or a guideline to manage patients. If a patient came back to the ICU with a peritoneal dialysis catheter in place, it would result in an immediate referral to the nephrology service. Sometimes we've been in the habit for really complex operations of routinely placing a peritoneal dialysis catheter at the end of the procedure, such as a Norwood operation. Letting the renal service know about that early postoperatively is helpful, because later in the middle of the night, if the patient does go into a period where their renal function is suboptimal, then it's relatively easy to promptly initiate peritoneal dialysis. And it's usually a low volume dialysis that's begun to try to clear fluid and maintain an even fluid balance even in the early postoperative day. Infectious complications are something we're concerned about with any operation, and we can divide those into superficial, deep infections, in the case of cardiac patients, mediastinitis, or infections related to some of our ICU interventions. Ventilator-associated pneumonias or line-related infections are common things we worry about in postoperative patients that can impact cardiac efficiency or overall outcome or duration of hospitalization. And then lastly, I want to focus on some endocrine problems. We don't usually think often with a lot of surgical patients about endocrine issues, but with the cardiac population, there's a couple of endocrine issues that crop up relatively frequently. I'll talk about adrenal in just a moment, but thyroid function is something that can frequently be abnormal in cardiac patients, largely because of the frequency of thyroid insufficiency, hypothyroidism in patients with Down syndrome. And many centers are in the habit of testing kids for thyroid function prior to undergoing elective operations if they have Down syndrome, knowing that they may be an increased risk even if the prior screening has been negative. Parathyroid or calcium instability is important because, as we know, calcium is an important cofactor in myocardial contractility. Low calcium levels can result in low cardiac output or poor contractility. And parathyroid problems or hypocalcemia can be very common in the DeGeorge syndrome or the 22q11 deletions that can represent a significant population, particularly in conotruncal anomaly patients. And then lastly, adrenal insufficiency. So adrenal function in cardiac patients can be compromised. And a number of years ago, we did a study where we looked at adrenal function in cardiac patients. We looked at both pre- and post-operative patients. We looked specifically at patients that exhibited what we called catecholamine-resistant low cardiac output syndrome. So they had an inotrope score of over 10. They had marginal cardiac output. And we did a functional assessment of the adrenals. We did baseline cortisol, we gave ACTH stimulation, and then assessed the response to ACTH. And then we looked at outcomes. We looked at total circulatory failure, which was defined as the need to go on ECMO or death. We looked at duration of mechanical ventilation, cardiac ICU stay. And we also looked at the hemodynamic response to giving steroids, exogenous steroids. And this graph represents what we found with the 63 patients that we had measurements for. So along the bottom axis, we have the basal cortisol level, and on the y-axis, we have the delta cortisol, or the response to ACTH of the cortisol. Did it jump up? And we didn't have any patients where they had a low basal cortisol that just didn't respond. So basically what would suggest an adrenal gland that's just not functioning. The majority of patients had a low basal cortisol but did respond to a CTH, suggesting it was more of a central adrenal insufficiency, more of a hypothalamic problem. Their adrenals were working fine, they just weren't getting the message to go ahead and make more cortisol. And that's distinctly different from other populations. People have looked at the adrenal function profile in adult and pediatric sepsis, which are the green and the yellow lines. And you get a whole mix across the board of patients falling into one of those 4 areas of that graph on the prior slide. Whereas with patients with congenital heart disease, what we found was the vast majority fell into the central adrenal insufficiency category, and far fewer in absolute adrenal insufficiency. And what's interesting is these patients typically do respond to exogenous hydrocortisone quite well, and the dysfunction is relatively limited. So it's in a couple of days with stress dose cortisol replacement, they can be weaned off and their adrenal function can be normal. So it doesn't necessarily portend problems long term, and we found that those patients with central adrenal insufficiency had a lower incidence of adverse outcomes and length of stay compared to patients that seem to have what we call the activated adrenal response, where their basal cortisol was in a normal range and they responded normally. So they seemed to be in low catecholamine-resistant low cardiac output, but didn't necessarily have abnormal adrenal function. And that wraps it up. Thanks for your attention.